working as senior resident in Meenakshi Mission Hospital. So today I'm here to talk about total intravenous anesthesia in neurosurgical procedures.
Good morning, Dr. Gayatri. Hello.
Sir, good morning, sir.
First of all, on behalf of ISA Vilpuram, I would like to welcome our speaker who has accepted this topic and who is going to deliver the lecture for the next 20 minutes on TIVA for neuroanesthesia. Thank you, madam, for accepting the topic. We can start the presentation, madam. Thank you.
Thank you, sir. So coming to the introduction, over the past years, neuroanesthesia has been rapidly evolving, and unlike other surgeries, as an anesthetist, the choice of drugs and techniques we tend to choose will have a great impact on perioperative surgical outcome of the patient. So before getting into the practical aspects, I like to brush up some important concepts in TIVA. So total intravenous anesthesia is the administration of anesthetic drugs exclusively via intravenous route. So in 1930, after the introduction of thiopentone, TIVA became common into practice. But only after 1990s, when the propofol has been introduced into the field, it became more safe and everyone started to practice it. So this three-compartment model, it explains the pharmacokinetics of the intravenous agents. So this is the basic of TIVA. So whenever we are starting to give TIVA, we have to know the general idea about it. So whenever the bolus is given, the peak drug plasma concentration rises, and after that, there will be an exponential decline in three distinct phases. So here B1 represents the central compartment, which equilibrates with the effect site concentration and from which the drug is removed from the body also. So here B2 and B3 acts as the reservoirs. So here the drug movement occurs based on the concentration gradient. So coming to the topic proper, TIVA in neuroanesthesia. So it became more popular because of three reasons. Firstly, the faster and shorter acting drugs that provides adequate plane for anesthesia. And secondly, it is due to availability of better models, that is computer-based model like TCA, target control infusion, which incorporates the pharmacokinetics of the drug with the infusion pump technology so that we can alter we can set the effect site concentration and we can alter it based on a clinical effect. So third is these IV agents provide better neuroprotection than inhalational agents. So these are all advantages of using TIVA. So by using TIVA, it provides hemodynamic stability and neuroprotection is better, and smooth induction and rapid emergence is seen, and low risk of post-operative nausea and vomiting, and of course, environmental benefits. And this picture depicts overall importance of TIVA in other system also. So in central nervous system, it reduces intracranial pressure, it reduces cerebral metabolic rate, and it maintains the cerebral autoregulation. And TIVA doesn't affect the flow metabolism coupling. And it has also advantages over other systems. In immune system, example, propofol, it acts as a free radical scavenger, and cardiovascular system, it reduces the inflammation after cardiopulmonary bypass surgery. So overall, survival benefit is better. And in post-operative pain, it also shows reduction in 24 hours pain scores. And in older patients, there is a reduced post-operative emergence delirium. In oncological surgeries, TIVA is linked with recurrence-free and overall survival. In GIT, it reduces post-operative nausea and vomiting. And renal system, there is also an evidence which reduces ischemia reperfusion injury. So why not inhalational agent? In neurosurgery, these inhalational agents destroys the flow metabolism coupling in a dose-dependent manner. So more than 1 MAC, it increases the cerebral blood flow and decreases the cerebral metabolic rate also. So thereafter, it destroys the flow metabolism coupling, and in evoked potential monitoring, inhalational agents affects it by increasing the latency and decreasing the amplitude of the potentials. So it also, inhalation agents also produces greenhouse gases, which affects the environment also. In which, like comparatively, TIVA preserves these flow metabolism coupling, and it doesn't changes very much in wave potential monitoring, and no greenhouse gas emission. So this table shows the effects of inhaled agents and IV agents on cerebral dynamics. So inhaled agents increases cerebral blood flow and increases intracranial pressure and decreases cerebral metabolic rate. So as I said earlier, the flow metabolism coupling is altered while using inhaled agents. And in intravenous agents, here cerebral blood flow is decreased and CMR also decreased, and ISP is also decreased. So ideal agent. So these ideal agents should have characteristics like rapid onset and rapid emergence, and it should provide adequate hemodynamic stability, and neuroprotection should be provided by these agents. So most commonly used drugs are propofol, dexmedetomidine, fentanyl, remifentanil, and benzodiazepines and muscle relaxant. So coming to the methods of infusion. There are various methods in adult and pediatric. So in adult, we can either infusion can be done by manually by calculating by our own, or else by using target control infusion. So manual infusion, commonly used drug is propofol. So this regimen is called Roberts and Bristol regimen, whereas 10 mg per kg is given for first 10 minutes, and then 8 mg per kg for next 10 minutes, and thereafter 6 mg per kg till the procedure ends. And then other drugs that can be used manually are remifentanil, fentanyl, and dexmedetomidine. So remifentanil, we can start by 0.5 mg per kg for first 3 minutes, and next 0.25 mg per kg till the procedure ends. And next method is target control infusion. Here, we can set the target concentration, and we can alter the concentration based on the clinical effect. So my general advice is not all patients are same. So each and every patient will have different pharmacokinetics, and volume of distribution will vary, and clearance rate will also vary between these patients. So there is no model that is superior. There are endless discussion that is which model is superior. But my general advice is to select one model, and we have to learn to use it. So for propofol, model like the Snyder and MASH. Here, like Snyder is effect site concentrating model, and MASH is plasma targeting model. So nowadays, we are commonly using Snyder model because of this effect site concentration. There is no lag time. But while using MASH model, since it is a plasma targeting model, there will be some lag time. So we